Welcome to Home Care Connection. I'm Harry Snyder from the Rutland Area Visiting Nurse Association and Hospice. Each month we bring a new topic about home health care services intended to make you aware of the many programs and services that are available through RAVNAH, and to keep you informed about the many resources available to you in the community. As more and more people learn and realize the benefits of being able to receive home care in their own homes, health care in their own homes, home care continues to grow and is expected to grow through the next decade. One of the main reasons why this growth is possible is because of advances in healthcare technology that have allowed us to provide healthcare services in a home when in the past they were only available in hospitals. Today, we're going to talk about the many advances in home healthcare. Whether you're dealing with chronic illness or recuperating from surgery, our trained staff at the Rutland Area VNA and Hospice will utilize the most advanced technology available to take care of you at home, which is where you want to be. Today, I have two outstanding clinical managers, both nurses, with me to explain the new technologies and how RAVNAH is helping patients manage their care at home. Please welcome Wendy Daly, Manager of Long-Term Care Services, and Sandy Eddy, who is a Clinical Manager of Home Care Services. Welcome.
Thank you. Hi, Harry.
So let's talk about these new technologies in home health. What are some of the medical technologies that RAVNAH is using now that have made an impact on home health care services?
Well, I think one of the biggest ones that has allowed more people to remain at home is our IV therapy. For years, people only received IV therapies, especially long-term antibiotic treatments in the hospital, which necessitated a long stay in an unfamiliar setting, and now we're able to bring them home with the technology that has been made more portable and available at home.
I remember over 20 years ago there when we were first started doing IVs with a man that had cardiac problems, and we were using peripheral access, and then it became very hard for us every 3 days changing the line, and gradually we were able to prove to the doctors in the community that the family and the patient were able to manage the condition, and we could, instead of making an ER visit for IV treatment, could do something at home, and gradually we're able to get access, long-term access placed. But that was a major change for everybody to realize.
Okay, so in talking about IV therapies, let's start right at the very beginning. What is an IV therapy? What does that even mean, IV therapy?
IV therapies are therapies that are provided especially to treat with antibiotics. We treat pain through IV therapy, hydration through IV therapy, chemotherapy. And IV means intravenous, which is a small catheter, flexible catheter inserted into a vein. And the line that we tend to deal with the most currently is what we call a PICC line, which is what they call a peripherally inserted central catheter, meaning it usually gets inserted about the junction of your elbow, and the catheter is threaded up into the main arteries. This is done under fluoroscopy, usually in the hospital. It's not something that we're inserting in homes yet. That may be coming down the line as time advances.
Correct.
We may be training to do that in home. But with the placement, you want to make sure that the tip of that catheter is in a central vessel. And having that placed, we are able to give more, quote, caustic antibiotics to the veins because it is a larger vessel. The dilution is better, so you're able to use stronger medications to kill the bugs that we tend to acquire either in the hospital or from infections.
Sure.
And with this IV access, we're able to teach the patient or the families the maintenance, and many were able to teach how to do the treatment in the home, the independence.
And I think that's an important part of virtually all of the services that the VNA provides its patients, which is education is a key aspect of the work that we do, is it not?
Yes.
So what types of patients receive IV therapies at home, usually?
As in today's society, one of our big problems is Lyme disease. So we are treating quite a bit of Lyme disease with antibiotics. We treat, excuse me, a lot of osteomyelitis, wound infections, bone infections. MRSA infections are treated with IV antibiotics, either vancomycin is usually the drug of choice, or gentamicin. Sometimes even for, some really severe urinary tract infections, what we call urosepsis, we treat with IV therapy at home. And those things normally people would be in the hospital for.
And often the treatment can be up to 6 weeks, that these
Yeah.
people needing the treatment, so many people not wanting to stay in the hospital, that continued length of time, when all the key thing is the IV they need.
So then, in a case like that, where maybe 10 or 15 years ago, I would have literally, in order to receive the appropriate treatment, which would have been through an IV, I would have had to stay in the hospital for
Correct.
upwards of 6 weeks. Now I may be released in just a couple of days and be able to receive
Yes.
this care in my home.
Correct.
It also, with the pumps that we're using, some people receive their therapy continuously, and they can carry a small pump that's the size of a small portable radio that they can put in a fanny pack or a back, and carry it with them, so it allows them to even go back to work.
Wow.
The activities in their home, be up and about.
Right, and
Yes.
not be tied to
An IV
a
pole in the old days.
And that's also huge. I mean, I would think, because being able to move around, if in fact I am able to move around, being able to move around has got to promote a quicker road to recovery than it would be if I was
Laying in
sitting
bed.
stationary, right?
Correct, yes.
When you think about the changes that have happened in IV therapies over the years, what do you see as what's really contributed to this this change in how is it that we're now able to provide this kind of care at home as opposed to what really changed?
I think the industry, the durable medical companies have come out and developed these smaller pumps.
Insurance companies.
Insurance
and
companies drive it because
Medicare will
obviously,
pay for it.
Yeah,
Oh, okay.
The
they will not
services
pay
and-
for the drug, but they
Right.
will pay
The
for the
services.
nurse to go and teach and administer the drug till the family or caregivers are comfortable doing it. But a lot of the savings comes from them being able to be in their own home versus incurring hospital costs.
No question.
And I think often where we can teach the patient or family, we're only doing the maintenance of going and changing the dressing and the cap change like weekly visits, and then backup if there are any problems.
Right.
Or with the pump or alarms going off, we're always there for backup of them calling us.
So when we have patients who receive IV therapy, is there an age restriction or anything like that? I mean, what type of?
No,
No.
None at all.
Because we
Actually-
have had some young children on it due to different problems. And then we've had all ages.
So any patient who is eligible for either Medicare or Medicaid,
Even your private insurances care.
Okay.
Correct, yes.
and then as long as the IV therapy is necessary, our nurses, and this is really a nursing service, is it not?
Correct.
Yes, high-tech. We have a high-tech team of nurses.
And what is it that determines what a high-tech?
They have gone through a training through our home health agencies of IV training, and then have been out and have been comped in doing the basic care,
Neat.
IV care with different pumps and different things.
So it's a specialized area of nursing services?
Yes, yes.
And so when a person is prescribed by a physician some sort of IV therapy, how does the training go out? Because I understand that our nurses provide education to the patient and their families,
Step-by-step procedures of how to do things.
and also the companies that provide the equipment, right, are involved in that as well, the durable
Yes.
medical equipment
They
people?
have, the companies that we deal with, the DMEs that we deal with, provide teaching manuals for their pump specific. They also have incredible teaching sheets that they incorporate with their drug deliveries. They do come and most of them make a at-home delivery and go through it. They can't actually do the therapy themselves in the home, so that the client, and if possible, sometimes even has a teach within the hospital setting before they come home. so that it's not something, another new thing when they get home.
Which makes
They've
sense.
had some exposure to it in the hospital setting.
I think the other thing with the IV therapy that has been a big step forward is the pain control. And people having the pump and being able to give themselves boluses, but in a controlled rate where the pump can be pre-programmed, but that the patient, depending on the severity of the pain, can give them extra doses of medication for some of the severe people with pain.
And actually, even talking about that, this is not, IV therapies aren't specific only to home care, right? There are also uses for IV therapies in our hospice program as well.
Correct, yes, yes.
And again, it's a similar, it is part of a prescribed medical plan of care.
Right.
And then our nurses come into the home and do education.
Yeah. But we are trying to improve the pain control with patients.
And the other thing we can provide through it is nutrition.
Oh.
Correct.
If someone has swallowing issues and the only way that they can receive nutrition, needing to even bypass the stomach and having nutrition go into the vessels, we do provide TPN, which is total parental nutrition, which is they're getting all their electrolytes and everything they nutritionally need through an IV line.
And we will teach the patients and families, and many are able and competent and
Very
able to do this
independent.
long term
Yeah.
for some patients.
And, you know, and I think it's really neat that you brought that up, because I think that, you know, to me, it seems like there are probably some pretty significant advantages for a patient to be able to receive IV therapies at home than in the hospital.
They can sleep in their own beds, they can sit in their own easy chairs, their dogs and cats can be at their feet. Sometimes they are a detriment with some of the lines.
Right.
We have had a couple gnawing incidences.
Right.
They tend to be an intrigue factor for little children. But all in all, they're able to be around familiar sounds, smells, family members. You know, in the hospital, a lot of people don't like to visit in the hospital, so
Right.
they're more comfortable coming to a home to visit.
And the rest, I think.
And the rest, if they can sleep in their own
necessary,
beds,
yes.
not being woken up every couple hours to be checked on or whatever.
Sure. And those PICC lines that you talked about, they provide, that's also an important part of how or why the therapies can be received at home. And what is the advantage to a PICC line versus
The
what
advantage
preceded it?
to a PICC line is it does not have to be changed every 3 days.
You do not have to be poked for blood, drawing blood, that we can
Oh.
get blood
Right.
for the blood tests that are necessary for some of these antibiotics. You need to have certain levels checked to make sure that you're tolerating the treatment.
Oh, really?
So they don't have to pick you. They can get the blood out of this. Many people appreciate that.
Right.
So in the same portal, is that the fair word?
Yes, there's usually two lines, one for blood draw, one for administering your medication.
Okay, so in this PICC line then, in this, if we're providing IV therapies, we can draw blood and then that blood is tested. What are the types of things that we look for?
Usually liver and kidney functions are the biggest factors that these heavy-duty drugs affect.
And the
also-
level of the medicine in their system,
Right.
too.
Okay, yeah.
Because you can get too much and they may have to decrease or change the dosage rate of the person's ability to tolerate it. They're giving high doses of some of these antibiotics to get rid of the infection in their system.
So in a situation like that, our nurses would go in, draw the blood, and then what happens to that
Doctor
point?
results a call to the doctor, and then he either alters the dose or he leaves it as it stands.
Which I'm guessing is a significant advantage to the physicians as well, because now they don't have to go make house calls,
Right.
and our patients don't have to go back into the hospital
Correct.
to have blood
Right.
drawn.
Right.
So is it fair then to say that a part of the IV therapy, the advances in IV therapy, have also provide some independence for our patients, and is that an important part
Oh,
of
most
this?
definitely.
Definitely, yes.
Most definitely. Because as I said, so many of them are able to, especially your insurance patients that really are feeling good, yet they still are carrying that infection, are able to go back to work. And that's,
Wow.
you know, in today's society, people can't afford to not be working.
And I think the insurance companies, less skilled nursing visits needed sometimes.
And some of them even are able to come into the office for dressing changes
Yes.
and that sort of thing.
We
So
did
it's
so.
more flexible, you know, if they're out, and it saves us too, because we don't have to travel to their homes.
Sure.
Correct.
I mean, it just, that is, I mean, to me, that just seems like such a gigantic change in healthcare, and the fact that that is able to be delivered at home.
It's been a big movement
It's
forward.
big.
Yeah.
Yes.
I would say that's one of our biggest advances that we've made.
Yes,
That and the wound care.
correct.
So I'm glad you mentioned that. Let's talk a little bit about wound care. When we talk about wound care, what are we really talking about as far as the types of services that our nurses would provide?
I think years ago, as they were doing basic dressings, were just a dry, sterile, wet to dry dressing. We would dampen a gauze and put it on, and then cover it with a dry, sterile one, and that was the most treatment. We've got 2 to 3 times a day doing a dressing change.
Wow.
But now with the advances and the ET nurse working with us, we get down to dressing changes every couple days, using some of the gels and some of the new treatments out. Then even we come with the vac dressing, where it's a suction type with a high draining, where we may have been going numerous times and layers of dressing. This machine will suck out the drainage, and a nurse needing to go only 3 times a week to change it.
So you said wet to dry, dry to wet? What does that mean, wet to dry?
Because you don't want the gauze that you're putting into the wound to adhere, yet you want it to have enough wicking ability, and then the dry on the outside to provide that wick out. To be the absorbent component.
That was a common dressing.
So then, so that was sort of more in the past type of dressing? The basic purpose of that is just what sort of keep the wound
clean.
clean?
Keep it clean.
And there's been so many advances, it's unbelievable with wound care. Now the wound care specialist for nurses too, now going for that added training to be able to provide newer, and it's day by day, new treatments coming out for wound care.
So, I mean, before we talk a little bit about the type of training and what wound care specialists have meant to us, so if we could just for a minute talk about the changes in just simply the wound dressing itself. So before, it was mainly about keeping a wound clean, meaning to prevent further infection, I guess, right?
Correct.
And now, what is a typical wound care?
You're trying to
Treatment.
stimulate the tissue now with
Right.
silver. We're using more ointments and gels with silver in it that they've found that stimulate healing. So
Oh,
we're doing,
really?
oh yes, all kinds, and then not needing to be done as much.
And one of the things too that I found is that it's less bulky. The new dressing, I
Yes.
mean, years ago the dressings, were 3 inches off a body part, and now they're, they can
Yes.
almost be fairly flush and non-apparent.
Wow.
You can put an article of clothing over it and not be as obvious that you've got.
I think with the often people with excessive edema in the lower extremities, we've got where we use Una boots a lot and needing only visits once or twice a week where we wrap them with the Una boot, which has become very effective. I remember years ago, I had a huge wound. I couldn't believe when the doctor said, go do this, the first Una boot. But I was amazed at the ability with the compression of how it healed.
Wow. So one of the biggest advances in wound care from the technology side of things is that wound dressings years ago, 10, 12 years ago, were really pretty much just to keep a wound clean. And now wound dressings actually make healing the wound even
Quicker.
help
Yes. Yes.
heal the wound.
Correct.
And you had mentioned a vacuum, a wound vac. What is a wound vac?
It's a foam, these are for your larger wounds that are draining excessive amounts of fluid, and this is where a sponge is put into the wound. And then there's tubing and a suction apparatus with a machine that will draw the fluid out of the wound,
Into a
which stimulates
canister.
healing.
Really?
Into a canister. It stimulates healing in the
Wow.
wound.
And I'm just guessing that if this wound is draining, that the fact that it is draining out of the wound area means that I'm changing that dressing.
Yeah.
I mean,
And we can use it on all locations. We have it on the abdomen, we have it on the knee, we have it hard around the knee with the movement of it, the ankle, many locations of this can be used on for
Wow.
wounds.
and those are usually more severe type wounds. Is that?
Yes.
Yes.
So
Deeper,
that's
bigger.
not some sort of a cut or something like that. That's
No,
draining.
there's pretty stiff criteria to have Medicare pay for one of these.
Medicare and Medicaid will, but there are, yes, very
okay.
strict
Yeah,
guidelines
they're very
that
strict
have to be met with
guidelines.
applications and going through the doctor, signing the paperwork, then going to the whatever payment source and getting approval before it can be started.
Which, again, I think that makes sense, because basically all of our services, no matter what, especially on the nursing side of things, there has to be some sort of medical necessity for the
Oh,
treatment.
definitely.
But it had been tested and then was proven effective. That before Medicare would pay for it, it had to go through a whole thing, and it has proven valuable.
So are there special skills that our nurses have for dealing with wound care? Is it an area of specialty, or is it?
One of the benefit that we have at RAVNAH is our contract with Kate Lawrence from Rutland Regional Medical Center, and she's a certified wound nurse, and she's been doing it for years.
Yes.
And there is special training. To do this training, it's now, I think it's 14 weeks at a surgical school, so to speak, that specializes. It's very complicated. And then there's national certification testing they have to take in different areas.
Wow.
And Kate's a great resource. You know, we get a referral initially. They've usually been seen by ET in the hospital. They come home with guidelines, and then Kate follows up within the home in conjunction with the nurse. So frequently you will see the nurse go twice a week, and Kate might go once a week.
Oh,
And then the
okay.
nurses also use her as a resource,
As a
though, of the
resource
patients
as things develop.
that they have, if they do have a wound, will call her and ask for advice of what. And she's been extremely effective working with the local doctors in
Oh, that makes
getting some
Oh,
of
yeah.
these newer treatments and different things tried, and it's proven that they are effective too in speeding up the healing of wounds. Many doctors will call asking for a ET eval, and that should be called in too. Special referrals just for her to work with us.
So this sounds like a pretty significant advantage that we would
definitely.
have in dealing with wounds, because it does sound like a pretty complicated.
Yes.
And I'm guessing there are other advantages to this affiliation with a wound specialist, whether it's directly related to the treatment of wounds, and what about even the potential for wounds? Is that a...
She has worked closely with our nurses and they have worked on a wound prevention whole protocol that we're working on this year with people, when the nurses going in, and certainly risk factors for
Wow.
people and trying to prevent wounds.
That
has
sounds
been a
pretty cool.
critical part of our nursing. When nurses admit, they screen patients and try and decrease and prevent wounds.
You know, especially your client that's in bed a good part of the time, that has poor seating situations, where they're putting pressure on bony prominences that they don't have much fat to cover because of their debilitated conditions, or even just general breakdown of their skin due to their diabetes or perivascular disease. I mean, the sources of wounds are not just surgical.
Right.
And that's where I think the nurses, the key thing is education. We're going in there.
Right, because
certainly,
we're not just treating the
educating.
wound, we're treating the
whole-
cause of the wound. So there's a
Correct.
lot of education
Education.
that's involved in, it's not just the wound treatment.
Right.
You've got nutrition treatment involved, education.
Position changes and the pressure relief of certainly going in, and if people need some kind of a mattress, some kind of a cushion that they're sitting on, of trying to be right on top of that.
So it's a team approach. In
I mean,
that
that
regard, we
sounds-
need to pull in therapy.
Absolutely.
Whether it be occupational, physical therapy. So it's definitely, wound care is not an individual treatment plan. It's a team approach.
And being able to prevent wounds, especially the kinds of wounds that we're talking about. I mean, where there could be wound treatments that take a significant amount of time for a wound to heal.
Oh, yes.
If we can actually prevent the wound from ever coming,
That is our
That
goal.
point.
I mean, that just seems like a gigantic
Yes.
advantage. That's wonderful. A few months ago, we talked a little bit on the show. Actually, we had a whole show where we talked a little bit about it. But another one of the advancements in home health, as I understand it, is telemonitoring. And you know, we talked a lot about back then the sort of specific aspects of telemonitoring, but from a big picture sort of advancement in home care technology, what does really telemonitoring mean to our patients and to the VNA?
I think this is where we've got a small portable device in the home. As long as they have a primary phone system, we're able to check at a convenient time for them their blood pressure, their pulse, the oximeter, what their oxygen level is, what their weight is, and it will be sent to a central station at the office, which we review. And then even though a nurse may not be going out there and assess them every single day, we are able to monitor their condition. And we'll follow up if we see like their weight, they've gained a couple pounds in weight, or their oxygen level is certainly down, calling them and checking on how they're doing, asking them possibly to recheck, was the information accurate? And then following up with the doctors, the information, we can send much more valuable information, daily information for the doctor to have to make changes possibly in their meds, and have made appropriate changes for some people, improving their conditions. And preventing and going to the hospital.
Right, it's very effective for our congestive heart patients. Years gone by, our biggest educational piece of these people is every day you have to weigh yourself. And if you've gained more than 3 pounds,
Correct.
you need to call the nurse. And so, it was just like, yes, for them to weigh themselves wasn't the issue, but then making that phone call was another piece that, one more thing I have to do. And this way with telemed, they can step on that scale. We know the weight gain, and we can give them a call and say, did you take your Layix today? Yeah, I did. Well, what have you eaten? What are you eating? So we know the target questions to follow up. I had 3 bags of potato chips because I really didn't feel like eating anything else. Well, then you've got your teaching mode. No, you can't do that. See what it did?
Right.
And that does seem like, one of the themes that has been consistent throughout the year that we've talked about home care is really this educational piece and this empowerment piece. I mean, our patients really are given power through education from our nurses or our therapists on the sort of, I don't know if it's the right word, maybe the pathology or the prognosis of the how their disease might be able to be improved or understood. And telemedicine, it sounds to me like if I'm seeing information every single day and I'm talking to a nurse daily or every couple of days about this stuff, it starts to make sense to me that if I have congestive heart failure where I may be prone to retain fluid, and I'm also eating salt, which helps retain fluid, that kind of conversation is a good one to have.
Yeah.
And maybe, sort of, oh, okay, you know what, I see that, maybe I should cut down on the salt a little bit.
Right.
And I'm guessing that there's also further communication improvements with telemedicine between our nurses and physicians, or is that not?
Yes.
And that's just simply a speed thing, or is it just?
We will fax. I think we have one lady that is very fragile cardiac status, and we're faxing the telemed information to her doctor in a local hospital weekly. The doctor has requested it for just him to keep up to date with and it's valuable for him.
Yeah.
He appreciates it.
We have about a minute and a half left. So I want to talk a little bit about home ventilators, because that sounds, in spite of the fact that we may not have a large number of people on it, the advancement there seems unbelievable to me. And if you could just take a minute and talk a little bit about the advancements in home ventilators, that would be great.
Home ventilators, as any of us that have been in the profession for years, you think of this huge and big, bulky machine that is your lifeline. They have now made them to the point where they're like small laptop sizes that mount on a pole, giving people that ability to have ventilation support at home. It's a very easy nuts and bolts hookup. The DMEs, yet again, are a big player in how this process all comes into work, because they are usually respiratory therapists, so they are right on top of what the settings need to be and all this sort of thing. They do an incredible teach with the family members to support them to decrease their level of anxiety. Oh, what if the alarm goes off?
Yeah.
What am I going to do? And they do come in and do an incredible teach. The alarm going off, don't worry about it. A tube could have just come connected.
And there is no question that if a patient were on a home ventilator 20 years ago, they absolutely would have been in the hospital forever.
Yes.
And now they can really do this at home.
Correct.
Well, this concludes our show. I would like to thank you, Wendy and Sandy, for being along with us today. time really has gone by very quickly. RAVNAH continues to assure that our patients benefit from the most advanced medical care available. Thanks for joining us on Home Care Connection. If you ever have any questions about home health care and how it can be provided to you or a loved one, please call us at 775-0568 or email us at info@ravnah.org. For Home Care Connection, I'm Harry Snyder.